Good afternoon. Thank you, members of the press, for being here again. I'm really pleased to meet the needs of your viewers and listeners. I think it's a really important thing you do, so thank you very much. It has been a very active weekend, and I think I'll just walk right through kind of what we've been working on. Starting off with the statistics, we've had, to this point in time, 368 positive coronavirus patients in the state of Kansas, representing 37, or I believe 38 counties and 8 deaths. You'll recall that about 2 weeks ago and about a week ago, we had projected that we would have between 300 and 400 cases at the end of March. Tomorrow's the end of March, so I think we're pretty much on target with that. It's always a little difficult, especially early on in an epidemic like this, to predict with great certainty. It gets easier as time goes on, but I'm pleased to see that, at least discouraged by the numbers, of course, because we want to keep those as low as possible, but encouraged by our forecasting in terms of the activity going on out there. We have had a death of a female patient in her 40s, in her early 40s, who had underlying significant medical problems that put her at increased risk of that. Did also an additional 70-year-old, 70-plus-year-old patient who died in Crawford County. Some things that I think are really worth paying attention to, and one is that we've had another outbreak in a skilled nursing facility in Coffee County, where I believe there's either 7 or 8 cases that have come up as positive. We're doing the epidemiologic work to make sure we do the contact tracing and find out exactly what happened there. Very worrisome to me, there was a church event in the state of Kansas. We've just gotten and just started doing the epidemiologic work with this church event. And the reason I bring it up in this context is because churches are not immune to having coronavirus outbreaks. And I know I saw in the news today that there was a church, not in Kansas, a different state, that had 500 people in attendance this weekend, elbow to elbow, shoulder to shoulder, for the entire duration of the church service. I've had many calls as recently as last week from people that I think, without getting into theology, I really think it's important that people understand that you do not crowd anywhere like that. The stay-at-home order is in place, and that goes for churches as well. So really pay attention to that. Let's talk a minute about the Kansas Health and Environment Lab. Some good news to share, actually. We at this moment in time, we have about 2 weeks supply of the test kits. We had one piece of equipment that came in with an engineer to help us get it started up. It's actually an incremental piece of equipment to the ones we now have that came in this past weekend, and we'll have a 4th one then come in this week that will increase dramatically our number of tests we can do, 700 to 1,000 tests a day. And we're looking at new testing methods that, in addition to the platform, as we call it, that we now have for testing, it'll be a completely new testing methodology, 45-minute-ish test, which will be much higher capacity for us, more rapid throughput. And the initial number of test kit that will come with that new method, hopefully by later this week, will provide a 65,000 test kits. So we're talking about a different scale. And the reason I bring it up in this context today is that, and you've heard me say this very consistently, that what we've been doing is diagnosing coronavirus, COVID-19, in sick people. What this increased test capacity will allow us to do, especially in addition to the commercial labs coming online. We are now doing about 30% of the testing in the state lab, and about 70% are coming from commercial labs. That has taken a tremendous amount of burden off of us. But we are still in this area, in the state of Kansas and the metropolitan areas, still focused on finding out when somebody's ill, is it coronavirus? So disease diagnosis, if you will. What this kind of testing capacity will allow us to do will be to do population studies. And that's, from a public health perspective, that's what we really want to do, which is beyond just diagnosing an illness in a sick person and the people around that person. It allows us to take it to the next step, which is to have distributed testing capabilities around the state, testing people who are well but might be infected and or shedding the virus. So there's a big difference between disease management, between disease diagnosis and management, and population studies to find out who do you isolate earlier, where are the problem areas of the state. Now, this may or may not impact greatly what this next month of April will do for us. But I think I can give you some assurance that we will get through this in April. There's no question about that. It's not going to be any fun, I will admit. And I think what we expect to see is that the number of cases will die down during the summer and spring and summertime. But I think, are pretty sure we're going to see a recurrence in the fall. So what this difference in testing strategy will do is allow us to anticipate and ideally to find people who are in or because people are putting others in themselves and others in harm's way. So when will we peak? We're still sticking with our original projection of probably around April 24th. Now, in many regards, it's a little bit like weather. If we're predicting tomorrow weather, we're going to be pretty good at it. If we're predicting 3 or 4 weeks or months out, it's not ever as easy. But I'm still sticking with the April 24th date. One other comment I wanted to make, and it's positive news, is that we got a shipment of 15 pallets today, a couple semis from the Strategic National Stockpile of the things that we need so badly, including masks, gowns, gloves, etc. And we have some really great homegrown initiatives coming on board with glove making and possibly new distribution channels. We're always applying new distribution channels to find the kinds of equipment we need. I'm going to turn you into a scientist for just a minute, and whether you want to turn into a scientist or not, I think it's something that I think you'll find very interesting. And this is the stuff we worked on all this past weekend, and that is the dynamics of this disease. Because without understanding how a disease acts, you cannot predict the number of hospital beds, the number of ICU beds, the number of ventilators, and that kind of thing you need. And by the way, there's many different competing models that started in China, European, University of Washington has one that a lot of people rely on. I've got those data here, by the way, which, by the way, agree with our in-house modeling. Penn has another one. So anytime you have competing and different assumptions built into predictive models, there's always going to be a little bit of a difference of opinion. It's like if you have 2 different television channels on predicting the weather, they quite likely will not agree. But let's talk about the dynamics of this illness. And that is, we've talked before about double time. How long does it take to go from 1 case to 2 cases to 4 cases to 8 cases? And one of the things that we do know, and it's exactly what we predicted because we saw it coming out of Spain and Italy, is the doubling time of 3 days. And the reason for the doubling time of 3 days is because, and we've talked about this infectivity factor called R0, N-A-U-G-H-T, R0 is 4.64. So that means for every person that gets it now, right now at this snapshot in time in the state of Kansas, that person will infect 4.64 people. That's what drives the increasing case numbers, and that's what drives the Nike swoosh. Follow that? Okay, stick with me for a minute. One of the things that we're seeing, and it's going to be very helpful, and we're getting a glimmer of it now, is that we all carry cell phones on us, and we know, I mean, I don't know, but there's tracking services that know how much are people moving around all the time. So you look at during spring break, and you imagine looking at a globe, there's like spaghetti all over with people traveling everywhere, right? And then after spring break, people came home and they kind of settled in, and you know what, with the story with COVID-19, people started saying, oh, I better stick around, I'm not going to travel as much. So there's a way to track that and measure that. And and you'll find this, I think, not only interesting, it's really important. And that is, if we say we are right now there's been over the last month, a 30% reduction. Let's just say that's true. If we can change that to a 45% reduction from the normal activities that people do, the doubling time, remember I just said the doubling time now is 3 days, goes to 6.6 days. So the swoosh got less of a swoosh. It's more dragged out this way, okay? So if we could reduce people movement by 45%, decrease the doubling time to 6.6 days, and the R naught, the infectivity factor, remember I said it's 4.64 for every one of you that get it, that it'll affect 4.5 people. That drops it to 2.5. So you don't have to be a mathematician to understand that that is a very pronounced impact, because then each of those 2.5, yes, goes to do 2.5, but that is a dramatic flattening of the curve, and that's where this is coming from. Okay, let's keep on with this discussion. It's kind of fun, and it's really important. People movement, let's say we could drop it to 55% reduction. It changes the doubling time to 9.3 days. So from going to where we are now at doubling time 3 days, 6.6 days, 9.3 days. That is a dramatic improvement by going to 45 or 55% reduction in people movement. It's very sensitive in terms of stopping the spread of this infection. So, emphasizing the importance of staying at home, contain it, let it run its course through get through the incubation period, and then see where we are. In the case of Governor Kelly, and we supported that, of course, was the stay at home until the 19th of April, and we'll be reevaluating every day. Something that's interesting to note is that the hospital stays now we're getting experience with it because we have more patients coming in, obviously, average 10 days, which is a long illness. That's a long respiratory illness. If a person goes into the intensive care unit, it's 14 days. And it's we're getting more understanding, of course, what kind of patients go in the hospital. Go at this point. This dramatically say receive. This is help of the. Give you one example. Use case. Because even at 45%, it needs 2,000 beds, which is, by the way, 1,000 beds more than what KU Hospital has. To go to 55% reduction in movement reduces it to the need for 500 beds. That is a dramatic difference. And by the way, that KU has that many beds. Because there's always, like at this snapshot in time like today, there's 400 patients that are there from completely unrelated things, unrelated to coronavirus. But that seemingly minor change of 45% reduction in patient movement, or people movement, to 55% pushes the need for 1,500 beds down. And that is dramatic. The private labs are picking up 72% of the testing, which we're real happy with. We're at the Cahill lab, 27.7%. Again, major philosophical change that will allow us to go do population studies and not necessarily just focus on the ill people. And then for those that are familiar with the University of Washington, who came out with a model, which is I have this 3 for fun: Kansas, Missouri, and New York here. We have the flattest curve of any of those, in the case of New York by a great deal. And what is one of the primary factors that pushed that down throughout all their states and territories was the states that closed their educational facilities have their lowest peak. And so kudos for, I think, good vision on the part of the administration for making that popular in some people's minds and unpopular in other people's minds. And as this model has emerged with the University of Washington, it's been a primary variable that I think will help us. I'm not going to turn you all into epidemiologists today. I'm really tempted to get out a whiteboard and start drawing graphs, but I think instead I'll bury that and just open for questions. Martin.
How many people carry the disease but just don't have any symptoms of it?
Well, until we do the population studies, we won't know. That's exactly the reason we want to do it.
And we now have a population of people who have had the disease and survived it.
Yes.
And this isn't a medical term, but that would seem to be an asset. People who have had the disease. Yes. How does one use that?
So, good question. The question is, what about those people that have gotten better?
Yeah.
And by the way, of all those hundreds that we have now, all but 8 have gotten, or I should say, many have gotten better or are on their road to that, and hopefully will continue. A couple things are buried in that question, Martin. One is we do not have the ability yet to test the blood with the antibodies that will tell us if a person will remain immune to it. But to the degree that we can drive up immunity, in a way that's like a bad way to. I'd rather have a vaccine to get people immune, but if somebody gets sick and they get immune, then that's great for them. And not just great for them, but great for the population, because again, the higher amount of immunity we have the lower the curves, the lower the peaks, spreads it out. It's exactly the reason why we want to have a vaccine. And then second point, and I know there was a second point that I wanted to make in there.
How do we?
Oh, can you ever borrow their antibodies?
Yeah. So
one of the question is, and we saw this with Ebola and other kinds of illnesses, if those people have circulating antibodies in their blood, can you do take off their blood, spin away the red cells, give them the red cells back, and keep the serum because it's got antibodies? And that has been shown to be effective for other illnesses and other situations. We don't have that as a recommendation yet. There's not enough body. We don't even know how to find the people if they even have those antibodies because we don't have a method to assay for that yet. But that would have promise to give antibodies to people that need them if they're in dire situation.
Just don't have that yet.
Just don't have it yet. So you're more of a scientist than what you thought, I think.
Do we know if any healthcare workers in Kansas have tested positive for COVID-19 yet? Are healthcare facilities required to report to you that specifically a healthcare worker has tested positive?
Yeah, the question, have healthcare people gotten? That's a great question. I don't know the answer to that. I suspect that if you include skilled nursing facility people as healthcare workers, then I think the answer to that is yes. I think that's worth finding out, and I'll see if we can get a glimmer of that, because we've been working really hard with assuring that there's testing of healthcare workers and first responders and others, assuring to the degree we can personal protective equipment and that kind of thing. I don't know the answer to that, and I'm not going to make up an answer, but we'll think about it for a future time.
And then along the same lines, because we know that there are shortages of the personal protective equipment, do you know if there are any healthcare workers in Kansas right now that are working without the appropriate protective equipment, or if it reaches that point, will you guys as a state agency know?
We may not know that. Direct and
Picking healthier people versus sicker people? Who gets tested at KM?
Yeah, we will design an algorithm to decide that. The difference is, and it's a good question, because it won't require a physician's authorization to do that kind of a test if we're doing a population study. I think that it's likely in outbreaks that you would tend to focus on the areas that are the hardest hit, so you can find everything you can find out about that community. Because there's this kind of concept of burden of disease. What is the burden of disease out there? We know who has the illness, but who has where is it lurking? And we don't know the answer to that, and hence that. But it would be healthy people. It would be people of all ages. It's highly likely, of course, that young people, even though are not ill or mildly ill at most with it, are probably the ones that will have some degree of positivity. Why else can you explain that closing schools had do that other in the springtime when they get a little bit more outside elbow room between them, a little less close proximity, but they're not crowded together in classrooms, and that may be one of the things that explains seasonality.
You say the 2-week window, that's about how many tests you have right now-ish. And then the increase for amount of tests you can do is going up as well. Is there only do something more, but now.
No, well, it wouldn't. With our current technology, even with our added platforms, it would now. But with this additional, there's one company that just on the 21st of this month got an EUA, emergency use authorization from the FDA, and they're a very high throughput one. I would like to see us get, with that technology, 700 to 1,000 a day so that we can analyze the heck out of the population in the area.
Is there a different rate of recovery among age groups or blood types that you found?
We've not investigated the blood type, but for sure the older the older one is, the less likely they are to do as well. Recovery is much greater in younger people with less concomitant disease.
And is 10 days pretty common? Is your son going to be done in 2 days, or how do you know? Or
don't really know. He's a big, strapping, healthy guy. And young, I think of 39 is young. So I think he'll be fine. But and it's fascinating to watch firsthand somebody on day 7 or 8. He finally got his appetite back, and I've never known him to lose his appetite. I think we'll find that it's a long recovery, but they get there.
Is it too early to tell if you recover from it? Can you get it again?
Too early to tell. It goes back to Martin's question about the antibodies. And without getting too deep in the science, sometimes there's what we call multiple serotypes. It's that the same organism can cause disease a number of different times. Dengue fever is one of those. If you get it one time, there's still 4 other serotypes that even if you're immune to the one serotype, you're exposed to it. They're like cousins.
Which nursing home is involved in Coffee County? And then same question regarding the church event you mentioned. Can you give us more details there?
It's the Life Care Center of Burlington in Coffee County that had the outbreak. And I'm saying that because it's generally known that is. I don't even know the name of the church or church event. We're just getting that information today. We will find that out shortly.
But what is the information you got about the church event?
That there have been people already hospitalized that had been we didn't know about the gathering, of course, until people started saying, oh yeah, I was at such and such, and somebody over here said, yes, I was at such and such, and somebody over here. It was just classical detective work that led back to it.
Is April 27th too early for the legislature to come back? You're saying the 24th might be the peak,
Yeah.
so that sounds a little close.
I think it would be highly unlikely that we would want to have people congregating in that manner that soon after the peak, because the peak, it means that there's still a lot of cases, maybe on the downhill slide. I don't second guess the legislature, but I think it would be unwise to gather people that soon after a peak.
You said the number is 30 to 45% or 45 to 55. Are those the numbers we're actually seeing in Kansas, or those nationwide? And then could we get higher? Is that realistic to say 80% of people are saying so?
I would love it. You know, I think if we could get to an 80% reduction in people movement, I think we would see the numbers just bottom out, and we'd get back to very, very quickly back to more normal. And I can't emphasize enough to your various audiences the need to do that. And again, this is not a game about trying to skirt around the exceptions and in the executive order. It's about staying home. One more question.
The Life Care Center in Burlington that you mentioned, wouldn't that then be the same chain as is involved in Springfield and Seattle and Wyandotte County? And if so, is that concerning?
I didn't know there was one in Springfield, but it's the same as in Wyandotte County. Well, and in Kirkland, yeah, Washington. I think they're a very big operator. So they've got many, many places, which would make them more likely. And I don't know about the epidemiologic work done up in Washington, but I know at the one in Wyandotte County, we didn't find anything that, and we didn't have any other tests come back positive on anybody, and we didn't find anything that would point to any particular problem with their standard operating procedures. It does make you wonder, but we'll help them sort through that to see if there's, sharing of staff or anything like that that would raise a red flag. Thank you very much, you guys.
Thank you very much, Doctor.
Did you get the VA